It's working. All right, well, good afternoon, everyone. Let's start this session. Welcome to the AAO session at the AIOS meeting. We want to thank the organizers of the meeting for letting us organize this session. We will have slight change in the order of the speakers. I'm here to introduce first myself. My name is Vishal Janji. I work at the University of Pittsburgh. I'm a cornea specialist. I have Professor Shizuka Ko, who's from the University of Osaka in Japan. Dr. Sonal Thuli is a cornea specialist and chair at the University of Florida, and Professor Tushar Agarwal is a professor at the All India Institute of Medical Sciences. We're going to discuss different topics all related to corneal diseases. We'll take questions after every talk. And without further ado, I'm going to request my first speaker, Dr. Shizuka Ko, to deliver her talk on dry eye. Thank you, Dr. Ko.
Okay, good afternoon, everybody. This is Shizuka Ko from Osaka University, Japan. It is my great pleasure to be invited to AAO symposium here today. So my talk is about understanding ocular biometry for cataract surgery in dry eye. I think this is one of the important topics. This is my financial disclosure. So as you experience every day, dry eye and cataract are very, very common in our clinic. So dry eye is a common disease that causes unstable tear film with an irregular surface. And also, currently, cataract surgery has become sophisticated surgery and not merely lens replacement procedure anymore. So why important? So this is a review paper from the ASCRS, American Society of Cataract Refractive Surgery several years ago. So what they say is insufficient ocular surface management can cause inaccurate preoperative biometry. And also it can cause poor postoperative results as well. Then it can lead to patient dissatisfaction for the surgery. So are you okay with this point? Okay, so today I organized my talk in the following way. First, I will talk about the impact of dry eye on ocular biometry. And next, I will talk about the preoperative screening for the presence of dry eye and abnormal ocular surface. So according to the DUCE 2, I believe all of you are familiar with this definition. Dry eye is a multifactorial disease of the ocular surface characterized by the loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. Although there is no visual symptom, but actually ocular symptoms can include visual symptoms. According to the Asia Dry Eye Society, dry eye is defined in the following way. So dry eye is a multifactorial disease characterized by unstable tear film causing a variety of symptoms and or visual impairment, potentially accompanied by ocular surface damage. Here is a visual impairment. So actually, all the ophthalmologists know that standard visual acuity test is not perfect. But however, in the real world, of course, general people and also non-ophthalmic doctors actually recognize that, okay, standard visual acuity test is actually good way to know the visual performance. But this is not true. Because one of the reasons is it is using the high contrast black and white letters. But in the real world, there are a lot of situations with low contrast conditions. So contrast sensitivity measurement is a measure of the ability to see low contrast patterns. Shown here is the contrast sensitivity chart, grading or letters at different contrast levels. Actually, it can estimate the visual performance close to real-world vision. Previously, we investigated the contrast sensitivity in dry eye. So if you rotated the contrast sensitivity chart 90 degrees, you can understand the result of contrast sensitivity chart very easily. So a green line indicates the result from normal, and pink is actually result from dry eye without corneal epithelial damage in the central region. And blue indicates the dry eye with corneal epithelial central damages. As you show here, so dry eye with corneal epithelial damage in the central region have the decreased contrast sensitivity and compared with others. Another reason for that standard visual acuity test is not perfect is because during the visual acuity measurement, patients can blink freely. But in real world, there's a lot of situations without actually less blinking. So we may have a possibility of the best moment visual acuity. Actually, in real-world vision, there are a lot of patients actually complain about fluctuation in vision. So since tear film actually constantly fluctuates, so we saw that ocular optical characteristics can be influenced. You know, since placebo-based topography uses the reflection of mirroring images projected onto the air tear film interface, so you can see you may experience that if you measure the dry eye patient, you may have such kind of distorted images. And if you actually have a chance to actually measure use the waveform sensor, it is also another way to actually see the influence from the tear film. On the left side, we previously actually measured the normal eye right after the blink and after the tear film breakup. So what we did is actually ask the subject actually to keep their eyes open for more than 20 seconds. So after the tear film breakup, you can see the distorted waveform spot pattern. And when we measure the higher duration sequentially after the blink every 1 second, you can see in normal eye, you can see the stable retinal images. But for the dry eye, you can see right after the blink, the retinal images are very actually decreased. Image quality is decreased, and dry eye has sometimes actually have very low actually tear film quantity. So there is no change during the blinks. So previous paper, recent paper actually reported that variability on ocular biometry from the tear film. So corneal curvature radius can be reduced in dry eye, and shortened breakup time associated with decreased measurement repeatability in corneal curvature radius and axial length. And also another press paper reported that tear film osmolarity can influence onto the keratometry data. Here is a paper from Korea. They investigate the impact of pretreatment for dry eye in IOL power calculation. So what they reported is pretreatment group had significantly lower mean absolute error in refraction at 1 month after surgery. And also they observed significantly lower refractive surprises. So next, we'd like to go for the preoperative screening. According to the Asia Dry Eye Society, dry eye can be diagnosed by the combination of symptoms and unstable tear film. So it is highly dependent on tear film stability. So just a simple tool, fluorescein, you can diagnose dry eye without any expensive fancy tools. Let's revisit the simple 3 steps in use of fluorescein. So please apply a minimal amount of fluorescein and shake well. Then apply please gently. So this is a very important thing to avoid kind of influence for the measurement. So again, there is no need for special devices. Just a paper strip of fluorescein helps dry eye diagnosis. So I'd like to share with you one case after the surgery. So this patient actually received the cataract surgery and a monofocal IOL was implanted. But right after the surgery, corneal epithelial damage occurred, and the referral doctor actually did a dry eye treatment, but they didn't actually improve. So he was referred without improvement with dry eye treatment. He has no history of systemic or ocular disease before. So this is shown here that his fluorescein staining for both eyes. So you can see the kind of dark area. In the right eye, these shapes are map-like. And in the left eye, these are kind of fingerprint. Unlike tear film breakup, there was no movement. So this is a case of epithelial basement membrane dystrophy. Redundancy of the cells within the epithelium form maps, cystic dots, or an irregular fingerprint. So this is also called as mapped London fingerprint dystrophy. So this is one of the causes for recurrent corneal erosions. Asymptomatic but may become symptomatic following surgery. He was actually asymptomatic before the surgery, but right after the surgery, he became symptomatic. So in its earliest of stages, it is often missed without a very careful exam. So I highly recommend actually to use a fluorescein staining before the surgery to all the patients. Here is another patient. So she actually received the cataract surgery and multifocal IOL was implanted. But after the surgery, she couldn't actually get a good visual acuity. So previous doctor actually exchanged IOL to monofocal. But for some reason, he actually didn't see any improvement despite dry eye treatment. So she was referred to me. So this is her images. So we can see the kind of slight haze. I believe it was missed. So I asked the patient very carefully. So she said, "Oh, I remember when I was a kid, a stone hit my left eye and it hurt. And after that, I thought that my eyesight had not deteriorated." So I highly recommend to close carefully, to see the cornea very, very carefully, and do not overlook the very, very slight haze. So such as iron foreign body and post-EKC and trauma. Some subtle or mild corneal abnormalities might be overlooked before the cataract surgery. So this is our previous results. So we prospectively actually screen all the patients before the cataract surgery, 101. And 30 patients are actually all excluded. But in the residual 71 eyes, we found actually corneal abnormalities in 60% based on the refractive screening criteria. Of course, this is a result from the university hospital, and also we have a bunch of actually variety of the surgeon and variety of the patient. We have to actually think about this. So again, this is very important. So it is up to you to screen the patient very carefully and use a fluorescein. So happy cataract surgery for dry eye patient, I suggest to optimize preoperative measurement and maximize postoperative outcomes and patient satisfaction. Thank you for your attention.
Thank you, Dr. Ko. Any questions from the audience?
Do you screen every cataract patient? Then do you do like the tomography on every patient, or is it just patients where you suspect something?
Thank you for a good question. So actually, so normally we did not do everything, every people, but for some point actually we are very interested in actually to know how actually the how much abnormality can be found even in the normal eye. But sometimes actually some very mild keratoconus patients know they have keratoconus just before the cataract surgery.
Perfect. Thank you.
I have another question. When we are planning these patients for cataract, we are primarily talking about a difference of about a diopter in measurement because of the dry eye itself. So when you do diagnose these patients with dry eye and they get started on certain treatments, so what happens with the biometry? When do you do the repeat biometry for the IOL power, and do you do it on the day where they have used the drops, or they are without off the drops, because those also influence the biometric evaluations?
Okay, thank you. I personally actually didn't any kind of study actually to see the changes without pre-treatment or pre-treatment, but definitely when our technician actually say to me actually if they have some cataract preoperative measurement for another doctor's patient, and she said measurement are very very unstable. So when I asked to check that patient, there is a lot of corneal epithelial damage, so I suggest to postpone the measurement. Preoperative measurement. Then I actually gave that eye drops and asked the patient come over again. And when I see the improvement, I can suggest the patient actually you can receive the preoperative measurement.
So, I agree with that. I was actually going to ask something further to that. Would you recommend, just for the sake of the audience, that we treat a patient who has obvious dry eye for about 1 month, 2 months, 3 months before repeating? Or?
I think if it is not actually emergency, but if they have a kind of retinal detachment, definitely we should go to the surgery. But if actually this is not an emergency case, I think we can just wait for maybe at least 1 month. I think it is better.
Okay. Thank you very much. Thank you, Dr. Kao. I would like to now invite the next speaker, Professor Sonal Tully. She's going to talk on IOL power calculations in post-keratoplasty eyes. Thank you, Dr. Tully.
Thank you. I want to thank Dr. Namrata and the moderators of this session for inviting me today. This is always my favorite meeting, coming to India and learning so much from everybody. So I'm going to talk about post-keratoplasty corneas. I have no financial disclosures. So why even talk about IOL measurements in post-keratoplasty corneas? Because they're just corneas, right? And there are some things that are a little bit different about corneas, and I was told to talk about PKPs, but we'll talk about the other corneal conditions too. But a lot of these patients, if you've done corneal transplants, you know that they end up with pretty significant amounts of either regular or irregular astigmatism, which can be a problem. A lot of them are wearing contact lenses, and then there's a whole conversation about would they be able to get out of these contact lenses they were wearing it for anisometropia or for ametropia, and they might want to get out of those contacts, and then determining whether or not they can come out of the contact lenses. And then in the past, we used to definitely look very carefully as to the age of the patient. If they were younger and they might need another transplant, that might affect the lens that you put into their eye, because they might be getting another transplant down the road. Now we know that a lot of the failed transplants we can recover by using endothelial EKs, which don't have quite as much of an effect. And so you might get away with doing things even in a cornea that might need replacement of some sort. And then we know that transplanted corneas don't always have the same posterior curvature, either in a PK where you have sutures pulling in different directions. You can't always predict that the posterior cornea is a certain percentage of the anterior cornea. And most of our measuring tools usually estimate what the posterior cornea is. They don't actually measure that. And that can be complicated when you're trying to do these surgeries. And then what if you need to have somebody that needs both surgeries done at the same time, and you cannot do one after the other? And so, just as a demonstration, we're going to talk about this one patient, and they've got some of those issues that we've talked about, where it's a 65-year-old patient. She'd had RK in the past and developed was wearing a contact lens and got a progressive fungal ulcer that was progressing despite everything we did, medication, intrastromal, intracameral, oral antifungals, and so had to undergo a therapeutic PKP. Fortunately, despite the lack of steroids, she actually had a clear graft, but had a mature cataract with posterior synechiae, and also had about 10 diopters of astigmatism, relatively regular astigmatism, but a lot. And we couldn't measure it on our regular biometry, neither the cornea, because there was so much astigmatism, or the axial length. We got the axial length by using immersion technique, so ultrasound, and then got a topography to get the corneal measurements. But again, difficult patient, and she never wanted to go back to contact lenses because she had this fungal ulcer developed from a contact lens. So she did not want to wear contact lenses, and we wanted to get rid of 10 diopters of astigmatism. And we decided to throw what's called the kitchen sink at her, do everything possible, right? She wanted to be as spectacle-free as possible. We knew we couldn't really get 10 diopters probably with any individual techniques. We decided to do a combination of different techniques. She really wanted these toric lenses because she had heard that they correct astigmatism better than other things, and maybe a little more predictable. And so we decided to do a toric IOL, astigmatic keratotomy, and compression sutures at the same time as her cataract surgery. And so one of the things that I really found helpful in this patient was intraocular aberrometry. So we used that when we did her surgery. We first put the toric IOL in her eye, and we managed to take about 4 diopters of astigmatism off. So she was left with, still against the rule, but about 6.5 diopters of astigmatism. So then I made some astigmatic keratotomy incisions on her eye, and lo and behold, I got a couple more diopters of astigmatism off, so now it was down to 4 diopters of astigmatism. So I decided to put some compression sutures in, and I did a super great job with that because she then flipped from against the rule 4 diopters to 4 diopters with the rule astigmatism, which we did not want to leave her with. So I took 2 of the sutures out, and now she was at about 1.5 to 2 diopters with the rule astigmatism, and we decided to stop right there. She healed up from the surgery and was a little hyperopic, but ended up, and you can see her compression sutures down there, ended up plus 1.25 plus 2 at 100 and was 20/20 with that, was thrilled because her other eye with the RK was also hyperopic. And so she was matched and was very, very happy. So you sometimes have to do different things when we're dealing with astigmatism. So when you are dealing with a lot of astigmatism with corneal transplants, one of the things to decide is, do they want to or not wear contact lenses, as in this case. So in her case, she had a lot of astigmatism, so we had to do a lot of things. But typically, if you have 3 to 4 diopters of astigmatism, maybe all you need is a toric IOL. But you have to be very, very careful that they're not going to ever wear contact lenses, rigid contact lenses, after the surgery. Because they wear a rigid contact lens, and now you've corrected their astigmatism with a lens in the eye, you're just going to manifest the opposite amount of astigmatism when you put the contact lens in the eye. So you want to make sure that they absolutely do not want to wear a contact lens afterwards. It has to be pretty regular. And you want to stop the contact lenses use at least a month before so you can get rid of any warpage they might have developed from their contact lens. And then you might need to do this combination of sutures, relaxing incisions, and a toric IOL. And oftentimes, if you're not really sure and you don't have an aberrometer, you can always put in sutures. It's always easier, I tell my patients, to take sutures out than to put them in. So you put excess sutures, and then you can always remove them after the surgery using topography. But you want to make sure that they're astigmatism is very, very regular. Now, if it's a very irregular astigmatism, as in this patient, you know you can't get away with just putting a lens in the eye or using compression sutures, and you want to use that little interface of their contact lens and the tear film under the contact lens to smooth their cornea, because as you can see, if you have an irregular cornea, there's absolutely no way to get one focal point. But the moment you put a rigid lens on top of the eye, between that and the tear film that's filling in the little crevices in the cornea, you can get a nice sharp visual point on the eye. So this person is condemned, unfortunately, to either having another transplant or to living with this contact lens for the rest of their life. Now, if they are going to be wearing a contact lens, then you can relax, right? And patients always want to see far away. They always come and you say, where do you want to see, far or near? And they always want to see far away because they haven't been able to see without glasses at a distance. This is very important for these patients to have to have a long conversation with them. You're not going to get out of your contact lens. Seeing far away is not going to be useful because the only thing you need to see without your contact lens is your contact lens. So I always make these patients about minus 2.5 for near, because at near, it's pretty forgiving. Even if they have an irregular cornea, they'll be able to see reasonably well. And once they can see their contact lens and put it in their eye, they can see far away. So you definitely want to make these patients myopic. You never, ever want to leave them hyperopic or distance corrected. Never use a toric lens, obviously, even if you do manage to map them out to if they have regular astigmatism, because if they're going to wear the contact lens, you know I want to wear a toric lens. But you can use corneal things that you can change to change their astigmatism. So if they have 8 diopters of astigmatism and you can put in sutures or do relaxing incisions, do whatever you want on the cornea, because that you can always replace with a different contact lens. But don't put a toric lens in the eye. Now these patients, there's no need to stop their contact lens before you do the measurements, because you're going to put another contact lens in their eye. If you missed your goal, you can always change the power of the contact lens. Another reason to leave them myopic, because if you mess up, they can always see at some distance. And then what about these corneas that are pretty regular, but again, you don't quite know what the true power is? If you look at their pupillary axis, you've got 2 or 3 different powers in there, and you don't know which one they're actually seeing out of. Here, the light adjustable intraocular lenses are very, very useful because you can touch them up afterwards to compensate for whatever ametropia you might have created by doing the cataract surgery. And then what about PKPs and cataract surgery together? Here, the keratometry is no longer relevant, right? My techs will come and they'll say, I cannot get K measurements. Well, I don't need K measurements. I'm taking that cornea off and I'm going to throw it away. So you don't need the corneal measurements from that eye. They then want to do corneal measurements from the other eye, and that's not useful either, because when you do PKs, remember, you're going to oversize that PK. And the reason why all of us oversize PKs when we do them with corneal transplants is when you cut the cornea from the outside and you get a certain amount of arc length. When you change that and you cut the donor cornea from the inside and you flatten it out when you're cutting it, you make it a little bit smaller. And so if you same size it, if you use the same size in the donor and the recipient, you're going to end up with a shorter donor cornea than a recipient bed. And so you always want to oversize it by about 1/4 if you're a small cornea, and maybe a little bit longer if you're a large cornea. But the problem is when you have a mismatch, because we can only mismatch by 1/4, but the difference is probably about 0.1, you're going to end up with a little bit steeper cornea. So the way to figure out your measurements is to look at your past history. Look at where corneas end up in your hands. And I have changed my power that I use for the biometry. So I tell them measure the axial length of the eye and then use 46 Ks. And that's what I use for all of my triple patients. And I've changed that over the years as I've gotten more information from my old patients. And so that's what you end up using. Remember that you can always touch up these corneas afterwards, but it's hard to do that. So you use a 46, you aim for myopia. Now the axial length is also going to be a little bit longer, and that could make them myopic, except the problem is that the increase in axial length is in the anterior chamber. So their lens is sitting further away from their cornea, and so that usually negates itself. So I typically just use the corneal curvature to figure out what lens power to use. And then, of course, when you do DMAC and DSEC, which is most of what we do these days and not PKs, with the DMACs, I usually wait, if possible, for at least a year to allow that cornea to remodel, especially if you've got a very edematous cornea. It's going to flatten out, and you might end up with a hyperopic correction if you do the surgery too quickly afterwards. With the DSEC, remember, even after years later, once the cornea is settled down, you still have to remember that the posterior curvature of that cornea is much steeper, because when you cut a DSEC from a lenticule, the edges are thicker than the center. So when you end up sticking it on the back of the cornea, the back curvature becomes much more steep compared to the front curvature. And so again, our measurements are off. So even if you get the most accurate measurements, they've been stable for a couple of years, remember that the back curvature may not be the same. So you do want to aim for a little bit of myopia in these patients, even if you're doing the cataract after the DSEC. That's all I have. Thank you. Happy to answer any questions. It is such a great job that everybody knows everything about it, right? Oh, the button.
Thank you for the very nice presentation. I learned a lot. So I have two questions. So for the if the patient needs wearing contact lenses after the surgery, when do you usually start actually using contact lenses? And also another second question is, I believe some patients are using corneal GP lenses, or some patients are using scleral lenses, and I'm not sure how much actually rate.
So the question was, how long do I wait after the surgery before I refit them with the
when you start, yes.
When you start the contact again. Now, most of them need the contact lens refitted after the surgery, so obviously they're not going to go back to their old contact lens. And so we're going to change the power of the contact lens after the surgery. Some of my patients are wearing bifocal contact lenses. I typically wait about 4 to 6 weeks after the cataract surgery before I let them get refitted for the contact lens. And then it takes them a few weeks to get that contact lens. So typically it's about 6 to 8 weeks after the surgery.
Okay, so how about the kind of contact lens? So how many scleral or corneal GPs?
So most of my contact lens people are not using RGPs very often anymore, and so most of my patients are in scleral contact lenses, and so it's the same time period.
Thank you.
Thank you for the question.
Thank you, Dr. Tully. You might not have an answer to this, but what about light adjustable lenses?
So I talked about that. Yes, so we do. Yeah. We don't do them personally at UF, but we do send patients for light adjustable contact lenses. I think it's a great option because it can compensate for that posterior curvature. And so in corneas where you're not really sure what the corneal power is, or they've got a multifocal cornea, having the light adjustable lens is beneficial. Even if you do all the measurements right and you get their visual axis just right, their angle kappa, they're still not right on the mark. And so light adjustable lens would actually be a good option for these patients.
Okay. Thank you so much. Thank you. Okay. Sorry.
Okay. Okay. So we'd like to invite Dr. Tushar Agarwal. His topic is post-refractive surgery. Please.
Thank you very much. Can I have my slides? Okay. So no financial disclosures. I'll begin with having a look at the timeline of refractive surgeries. It started all with RKs. It was in vogue from about 1980s till about the middle of 1990s, following which LASIK took over and is still continuing. It started with microkeratome-based LASIKs, and now it's mostly femto-based LASIKs. ICL has been here since about 15 to 18 years, and then SMILE has been there. Why I show this slide is that when these patients underwent radial keratotomy, assuming they were at least 20 years old then, these are the patients who are now 60 or 70 plus and going to be presenting with cataracts now. And as we move down this list, the number of patients as of today will go down and down. So in my own OPD or practice, I see about 2 or 3 patients every month with previously operated refractive surgeries, and the ratios match this data. That I see about 2 RK patients for every 1 LASIK patient who has undergone some kind of refractive surgery who have come for age-related cataract now. I've yet to see a patient who has undergone SMILE and has presented with cataract. ICL, of course, we do see cases who need cataract surgery, but those are primarily who have developed cataracts because of the lens itself. The point of showing this slide is that these were the patients who were very fastidious about not wearing glasses at all, and had taken those risks at that time. They go in for neurosurgeries, so their risk appetite is higher, but so are their expectations, which have to be managed at the time of cataract surgery itself. Now, when we talk about post-refractive surgery IOL power calculations, there are 2 issues at play other than the psychology of the patients involved. It is the measurement of the biometry. The anatomy itself is distorted, so whatever instrumentation which we use, it works on some kind of assumptions, especially where keratometry goes. So when you do a laser-based refractive surgery like LASIK or SMILE, all those assumptions become invalid. And similarly, when a patient has undergone RK, especially if it has flattened and it is still going under a hyperopic shift, all those assumptions when we do keratometric measurements again become invalid. Primarily, all formulas have same weightage to various biometric parameters. If you have an error of 1 millimeter in axial length measurement, you will end up with around a 2.5 diopter error in postoperative period. Similarly, keratometric evaluation, if you have somehow you end up with a 1 diopter error in measurement of keratometry, then you will expect an error of 1 diopter post-op in the postoperative period. So I'll take out axial length out of the way first. We, in fact, did a study a long time back where we measured axial lengths after the implantation of ICLs, and we found that they make no difference in terms of axial length measurements. And regarding the laser refractive surgery, it works slightly differently, which I'll take up slightly in a later slide. Now, the problem with the keratometry is that it fails to accurately capture the central keratometry, especially in cases of previous refractive surgeries. Now, what happens is that it measures the paracentral points at 3.2 millimeter zone, and there is a flattening shift as you move towards the periphery. And the older generation biometers do not take this into account, and they also don't measure the posterior corneal surface, which has also been altered. So what happens is that if a patient has undergone a myopic LASIK, you will tend to overestimate the K and end up with a hyperopic shift, and you will underpower your lens. So if the power required was 20, you will probably put a 15 diopter lens if you go by the conventional methods, and vice versa for hyperopic LASIKs. So the other thing which I said, I'll come later, the axial length measurements. So they may not directly affect the axial length, but they do affect the effective lens position, which is actually taken into account with the newer generation formulas. So now we have come to 2 sources of error. One is the primary inaccuracy in measurement of the biometric values, and the assumptions which go wrong when any of the conventional formulas actually calculate the IOL power. So historically, various methods have been described in literature. Especially these came out in 90s and going up to 2000s, when the primary sources of information were the keratometry and the ultrasonic axial length. This is pre-IOL master era, where optical axial length measurements and ray tracings were available. So you would have things like clinical history method, contact lens method, where you will fit the patient with an RGP lens. I believe some people still follow that method because it gives a very accurate measurement of the anterior surface of the cornea. And then you have various adjustments which were followed. Before the optical biometries, we also used to follow that a very good empirical formula used to be that you follow the conventional keratometry findings, input them into the formula, and then you add 30% over it. And that used to work quite well. It still does quite well if other measurements are not available. So total keratometry was a new concept which combines the telecentric keratometry and swift source OCT for assessment of both the anterior and the posterior corneal curvature. So what this does is that it takes into account the alterations done to both the anterior and the posterior surface of the cornea, and this is what is incorporated in the newer versions of the IOL Master. Then you have recently machine learning based IOL formulas which are being used now. People are using them, have reported very good results, although I have no personal experience with them. Then you have intraoperative measures like ORA, which actually do a wavefront analysis on the table once the lens is out, and you can get an on-the-spot reading of the IOL which has to be measured. These work especially well if you are unable to get any sort of reliable reading in the preoperative period. If we look at literature regarding which formula works the best, we will find that you could have two cutoffs where you could measure success. If you go by 0.5 diopters of IOL surprise in the post-op period, then most of the formulas do tend to induce errors. But if you keep that cutoff at 1 diopter, then you get much better results. But you will find that on one end of the spectrum, you will find all the ray tracing based calculations, and the middle would be the Barrett's, or the Barrett's True K, which I frequently use, and on the right side are the traditional formulas used with various corrections. Again, this slide, as I mentioned, the dark green represents the eyes following in 0.5 diopters of post-operative error, and the light green incorporates, it goes up to 1 diopter. So if you carry the cutoff at 1 diopter, then most of the formulas tend to do very well. ORA seems to be the method of choice if the readings are not available preoperatively. I'll look at a few of the cases and try to share my understanding and working algorithm. So this is a patient who had undergone RK and was planned for cataract surgery. So the way we look at is that we try to get the measurements from various instruments which we have at our disposal and try to look at comparability across the magnitude and the axis of the astigmatism. If that is consistent across various instruments, then we tend to rely that, okay, the readings are more accurate. If the corneal aberrations are very high, we will, most of the cases, we tend to go for monofocal IOLs. However, if we find that the internal aberrations are higher, but the corneal aberrations are very low, then even multifocal lenses are planned. So if we are planning for a toric IOL, then what we are looking for, as Dr. Tully also showed in one of her slides, if you can make out a bow tie pattern on the astigmatism, and you can get a consistent axis across at least 2 instruments, then you can be pretty sure that of your measurements. And so this patient underwent a toric IOL implantation following this. So this is a patient who underwent LASIK and had a cataract. And again, as I said, the HOA were within normal limits, and the angle alpha was also acceptable. So this patient was planned for a toric multifocal lens. So another patient who has undergone RK but also has Salzmann nodular degeneration and is planned for cataract surgery. In fact, this patient is yet to undergo cataract surgery. And what I want to stress here is that even if you run various formulas, you will find the IOL paths which come out in a range of errors. So what you are looking for is to choose the PAR on the highest possible end of the spectrum. So you want to put the highest PAR which any formula is giving. That would, because the chances of going under are much higher than going over. Despite all our precautions, still we end up with refractive surprises. And as I mentioned in my first slide, these patients really don't want to wear glasses. And so we do need to be slightly more aggressive with these patients in management. So what are the various options? If there is a very small magnitude of error and it's a myopic, another reason for targeting myopia in these cases, these can be managed by a PRK or a LASIK following cataract surgery. If there's a misaligned IOL, it can be quite easily managed with IOL rotation. If there is a great hyperopic error or an IOL surprise, which is quite common, especially if the preoperative evaluation missed the surgery itself, then piggyback lenses are a better option. And if piggyback lenses are not available, or if the magnitude of refractive error is very high, then the final choice is to do an IOL exchange. Although again, this compounds the problem even further, because now the toric IOL also has to take into account the surgically induced astigmatism caused not only by the previous surgery, but the increase in astigmatism which is going to be caused by the IOL explant itself. Last couple of slides where I'll introduce a new concept which we have been working on, the concept of, so this was the original paper on EDOF lenses. So it was interesting that they hypothesized that the EDOF lenses, which they basically work by, so a monofocal lens has a single plane of focus, a bifocal diffractive lens has two planes of focus, but an EDOF lens or an enhanced monofocal lens has an elongated plane of focus. So they said that they probably work better in astigmatism because it spreads out the area of focus itself. So we tried these lenses. We have been trying these lenses in patients who have undergone previous corneal refractive surgery to further give us a cushion for preventing IOL surprises. And we found that although there was no statistical difference, but there was a trend, probably because of the lower sample size, which had these patients had a better uncorrected visual acuity. They did, however, have a much better near visual acuity. And post-LASIK patients did better than post-RK patients. In conclusion, for central corneal power, more than one method should be used. You are looking for consistency of measurements across various instrumentation. Again, we use the Barrett-Struke and the Hegel formula to calculate the power, and we normally go for the higher power which either of the two formulas gives. We tend to err on the side of myopia wherever possible, because even if A, the myopia is going to be less bothersome, and B, it is still correctable by a future PRK. And we do plan a toric IOL in these cases, but only if the magnitude and the axis of astigmatism are consistent across various instruments. And one has to go an extra mile to counsel these patients to temper their expectations, as they really don't want to wear spectacles. Thank you.
Thank you. So is there any question from the floor?
Can I ask a question? So that was a fantastic talk, and we're seeing more and more of these patients, obviously, and they will keep increasing as more people.
They are increasing because now the LASIK patients are also coming into the pool.
Exactly.
And one more thought, that they're tending to present earlier than the RK patients.
They are.
So probably something to do with either the baseline myopia, which is a risk factor, or something to do with the laser
the
itself.
laser itself.
Yes.
I've wondered about that, because they are much younger.
And they're harder, and the cataracts
Yes.
are harder than their age. So yes,
Exactly.
I'm sorry, the question.
No, so my question was actually about about the EDOF lenses, because so theoretically, one of the things that bothers the RK patients a lot is that fluctuation in the vision, right?
Yes.
And the measurements too.
Yes.
You measure them at 10 o'clock in the morning,
Yes.
you'll get a different IOL power than if you measure them at 4 o'clock in the afternoon.
Yes.
So is there any benefit then, besides the meeting the expectation, just so that you increase their range of where they can see?
Okay.
And so doing two measurements and then using an EDOF that would hit both those numbers, so that they always...
I really haven't thought of this thing that it might help them, even in the fluctuation.
Right.
The initial thought was, when we read this paper and we picked up the idea from there, was that, okay, so it does give you an extended depth of focus. So even if there is a small, because these are the patients who actually end up with, because now with the current technology, the other patients, we don't touch, we don't see IOL surprises now. It's pretty accurate. It are these patients who want a zero power and they end up with IOL surprises, paradoxically. So we thought that, okay, it will give us a small, a slightly longer range than normal. And we did see now, after we did the study, now the EDOF lenses have come with toricity also.
Right.
So this is what we wanted to do actually when we started the study. That would have been the ideal comparison which we are starting now, that to compare. So if it offers any addition, the toricity, if you you take toric lenses in two groups and add EDOF on top of it.
Right.
Now, if that gives a better sort of range of vision, talking temporally in terms of the time or even in terms of the post-op refractive error,
right,
then it will actually validate that concept that yes, it tends to compensate for a small degree of refractive errors, because we calculated the defocus constant. I did not show those graphs. So you can see that the defocus values, which is that how much defocus you can tolerate. So these patients can tolerate up to 1.5 to 2 diopters of defocus.
Wow.
And that's the range you are, sort of a cushion you are getting against IOL surprises. So it worked in these patients on a small sample size, but the ideal comparison would be with a toric lens with and without EDOF.
Yes. That would be exciting. To next project for you to do,
Yes.
Tushar.
Thank you.
Can I ask one quick question? So I believe one of the another complication with post-RKI is actually decrease corneal endothelium actually dysfunction.
Sorry, cornea?
Decrease the corneal endothelium.
Yes.
Epithelium.
Yes.
So I think maybe we can do the cataract surgery, but maybe there are some patients whose actually corneal endothelium is actually significantly decreased. So in such cases, what to do?
So we see patients who have had more than 32 incisions also. And almost the clear part is much less than the scarred part. So a couple of modifications which we do is that we go for quite posterior incisions, almost with a peritomy and scleral tunnels, so that the entry point is actually before the start of any incision. So that's one modification which we do. Second is doing the entire surgery under viscoat, replacing it, replenishing it after a certain set. So we have set criteria we monitor the CDE, the cumulative dissipated energy, and after every certain intervals. So the 10 is the upper limit where we'll replenish the entire thing with viscoat. And the third thing is that the implantation is done not wound assisted but in the bag implantation, so that there is no additional stress so you enlarge the incision slightly so that the cartridge actually opens in the eye and the lens slides slightly directly into the eye without coming into contact with the cornea. And last but not the least, the viscoelastic removal is done by bimanual, not with the eye, because those are the times where you have maximum endothelial cell loss when you come out after the IA. So we keep the chamber at all times.
Thank you.
Thank you.
Okay, thank you for the wonderful talk. Okay, so I would like to invite Professor Bishar Janji. His topic is acute corneal hydrops. Please start your talk.
Thank you. So, Doctor, Yamaguchi is not here. In case you're wondering, I'm not going to talk about IOLs, but we wanted to fill the session, and I want to talk about keratoconus. I don't have any relevant financial disclosures. So when you talk about keratoconus, it's characterized by axial, central, or paracentral corneal thinning and progressive irregular astigmatism. Estimated prevalence can vary depending on where you are, where you practice. It usually presents in the second decade of life, but we've now started to see more patients even at an earlier age, possibly due to better diagnostic modalities. It can present variably. You can have patients who will come to you with changing refractive error, changing prescription on glasses, myopic astigmatism. You see the case of facial rings, corneal scarring, and sometimes the acute corneal eye drops as well. So we're going to talk about the eye drops here. The pathophysiology of eye drops is pretty clear. There's a break in the descemetes. Aqueous seeps into the stroma, causing acute corneal edema. Patients present with sudden decrease in vision, onset of pain, and usually a lot of photophobia. Non-surgical managements, basically they aim at decreasing the stromal edema. You can use hypertonic saline as eye drops or ointment. Some physicians would like to lower the pressure as well, using either topical medications or oral acetazolamide as well. It is important to control the pain, which usually responds well to cycloplegia and some lubrication as well, because the surface becomes there's microcystic edema and early bullous changes, which are of course temporary. The goal is to prevent corneal neovascularization, because if this patient needs a corneal transplantation in future and they develop corneal neovascularization, the prognosis is going to change. So there is a possible role of topical steroids. We usually don't use them, but that's the importance of following up the patient on a regular basis. This is a 22-year-old male who has bilateral keratoconus. Right eye cross-linking was done, left eye was waiting for cross-linking and still thinking about it. He presented 4 months later with acute eye drops in the other eye. You can see the interior segment OCT shows fluid-filled pockets and an increase in corneal thickness. There is a break in the descemetes membrane, and of course then there is sudden drop of vision. We talked to the patient, started some cycloplegia, tried to dilate the pupil, making sure he was comfortable, and we asked him to come back for follow-up. In 2 weeks, you can see there's further drop of vision. Look at the clinical picture and look at the ASOCT. Now the fluid pockets, they're sort of merging together. We give an option for intracameral injection of air, just to sort of, expedite the resolution and provide him some comfort. Patient refused and said, I'll think about it. The patient comes back at 4 weeks, and you can see that actually the eye drops is even worse. There is now a huge pocket, almost a cornea within a cornea. Of course, the second cornea is only fluid and nothing else. So this is 4 weeks. The vision is pretty low. Our view is quite bad as well. So we're thinking about what to do. And of course, the patient said, well, I'll come back again. At 8 weeks, the patient suddenly presents with resolution of corneal edema. So this case history just highlights the natural course of the disease over a period of 8 to 9 weeks. So even if you don't do anything other than talking to the patient, basically the edema is going to resolve itself in most of the patients. If you go ahead and do surgical intervention, you might, especially intracameral gas or air, not that it doesn't work, you might end up inducing pupillary block glaucoma or even cataract in such a young patient. Surgical management, as I mentioned, most commonly is intracameral air or gas injection. It shortens the duration of corneal edema. You're basically tamponading that break, which enhances or expedites the resolution of edema. You can use AMT, amniotic membrane transplantation with cauterization. I'll show you a couple of pictures. And of course, rarely you can perform a keratoplasty for a large descemetes membrane tear or intrastromal cyst, although we don't do it anymore. A bit about intracorneal air or gas injection. It shortens the period of persistence of corneal edema. You can use air, 20% SF6 or 14% C3F8. Air works as well as anything else and actually is preferred over isoexpansile gases. You have to preoperatively constrict the pupil, make sure some fluid is taken out of the AC before you inject anything else into the AC. We usually fill the AC with 2/3 of the volume. Post-operatively, it's better to have supine positioning, topical antibiotics, hypertonic saline, and now you can give steroids because you basically entered the eye, and you can lower the pressure as well because there's always a risk of complications, which definitely include elevation of IOP. You can have some endothelial damage, although you wouldn't worry too much about that because there's a break in the decimates. You can induce cataract, which can be worrisome. And of course, your gas can migrate into a place where you don't want it to go. This is a study we did ages ago, 2011, just showing the evolution and resolution of eye drops using UBM. At that point, the anterior segment OCT was not as developed as it is now. This is a picture of a patient who had intracriminal gas injection. You can see the edema resolves quite quickly, especially in the first 7 to 10 days, actually. You can take out some fluid, doing intrastromal fluid drainage with air tamponade using anterior segment OCT. We published this series about 10 years ago now. And again, at that point, we did not have access to intraop OCT. You can actually repeat this. You can actually do this better if you have access to intraop OCT, where you can actually see where the fluid pocket is and then make sort of an incision there. This is a video which basically shows that you can. So you basically make a paracentesis, fill the AC with air, and then you preoperatively know where the fluid pocket is. You can drain the fluid, very carefully. As I said, this looks easier and less dangerous when you have access to intraop OCT and you can make more than one incisions. You can see you're basically helping quite a bit. That amount of fluid that egresses out is significant, so there's no doubt that the edema is going to resolve quicker. Rarely you can use AMT with cauterization. This was published back in 2006 in 10 eyes with where multifocal cauterization of cornea was done, and eye drops was resolved quickly. It's supposed to be a highly effective treatment for persistent eye drops related to keratoconus. And there's actually a good publication in late 90s from Sheffer Sengh's group where they have consistently used this for patients who have eye drops and are differently able, especially patients with Down syndrome. We published a short case series where we actually use electrocoagulation using a commercially available machines. You actually end up putting about 50 spots on the surface of the cornea, which basically induces scarring, superficial, and then that leads to resolution of edema. We don't do that often unless the patient, as I mentioned, is differently abled. So to conclude, most of the times, conservative management is good enough, as you saw in that case study. If you have to, you can use intracameral gas tamponade. The most commonly used gas is air. You can do corneal stab incisions, especially if you have access to intraop OCT, and image-guided intervention just makes the whole process actually very safe. Thank you very much for your attention.
Thank you for a nice talk. So is there any questions or comments from the audience?
Just a practical question, Vishal. They're not working. For gas, because these patients are phakic and you don't have a PI, do you leave a full fill of air, or do you then after a while take some out, and do you dilate their pupil afterwards?
Yeah,
That's what my worry is after.
Yeah, we basically do the same thing as we do in EK nowadays. So
you fill it up completely and then remove some?
Yes, you can. You can actually do a PI as well, although, and again, I have to confess that I treat more than 90% of patients just conservatively because they resolve. Of course, sometimes the patients, they are starting to develop neovascularization 1, and sometimes they are in a lot of pain and they want quicker resolution. So you can fill the AC completely, wait for some time, and then reduce it to 2/3 and dilate the pupil. There is still a risk of pupillary block sometimes, but it's not as much. And that's why I prefer air over other gases.
Rather than gas.
Dr. Vanathi from RP Center had published a case report where there was actually a retroflexion of the iris, complete, following injection, I think, gas after keratoconus, eye drops, and the patient had a malignant glaucoma following that because of misdirection of the entire thing went posteriorly because of the pressure. So it's better to leave some gap. It has to be burped out a little bit.
Okay, thank you very much. Any questions from the audience? All right, this brings us to the end of the session. I want to thank all the speakers and my co-moderators and chair. Thank you very much. Have a great rest of the afternoon.